Hi, I'm Jim Smyrniotopoulos, and this is MedPix Case of the Week, number 602. If you want to log in for CME credits, please go to medpix.usuhs.edu. This 17-year-old girl had a head CT scan because of severe headaches. The CT prompted a second follow-up scan using magnetic resonance imaging. This axial non-contrast CT scan shows normal ventricles and sulci for the patient's age. The frontal horns and the third ventricle do not appear obstructed, and the quadrigeminal plate is in its normal location. However, there is an obvious mass lesion, a rounded, homogeneously hyperdense mass located near the anterior third ventricle in the approximate location of the foramen of Monro. If we look at the CT scan and then compare the follow-up MR scan, we can see a corresponding hyperintense lesion in exactly the same location at the anterior third ventricle at the junction of the frontal horns of the lateral ventricle and the third ventricle. This lesion is most likely going to be a colloid cyst. We can see here that after contrast enhancement, the internal cerebral veins surround the lesion, but the lesion probably does not show any contrast enhancement. So what is a colloid cyst? A colloid cyst is approximately 1 to 3% of intracranial masses. It is a congenital fluid-filled space lined by an epithelium. It represents about 1 out of 5 or 20% of intraventricular masses. It is almost exclusively located within the third ventricle, usually attached to the anterior roof of the third ventricle at the foramen of Monro. This is a congenital but slowly growing true cyst. The lining looks like respiratory epithelium or endoderm, and it has cilia, blepharoplasts, and goblet cells. The cyst slowly expands over decades as it fills with mucus secreted by the lining, growing to 15 to 35 millimeters in diameter over a period of 15 to 35 years. The symptoms and morbidity from the colloid cyst are directly related to mechanical obstruction of the CSF drainage from the lateral ventricles at the foramen of Monro, causing obstructive hydrocephalus. If we look at this coronal MR scan from the same patient and a corresponding diagram, we can see that the mass lesion is located right at the Y-shaped junction between the lateral ventricles and the third ventricle. If there is obstruction at the foramen of Monro, the lateral ventricles will expand and they will produce a corresponding enlargement of the cerebral hemispheres and increased intracranial pressure. Normally, cerebrospinal fluid is secreted at about 20 milliliters per hour, and the total volume of both lateral ventricles is typically less than 35 millimeters. If we look at this sagittal MR scan, T1 weighted, we can see another example of a hyperintense colloid cyst in the anterior third ventricle, and we can see the relationship to the fornices. Symptomatic colloid cysts tend to present in younger patients. They tend to be larger diameter cysts, typically approximating 15 millimeters. Symptomatic colloid cysts are usually associated with visible enlargement of the ventricles, and they are typically bright on the T1 weighted scan. Here is another example of a symptomatic colloid cyst. This 36-year-old man presented in cardiac arrest and had an emergent ventriculostomy. We can see a large rounded mass in the anterior third ventricle, causing obstructive hydrocephalus of both lateral ventricles. On the coronal image after gadolinium, we can see that there is a thin rim of enhancement surrounding the fluid-filled space. The natural history of the colloid cysts is that they may become symptomatic as they enlarge and cause CSF obstruction and ventricular enlargement, leading to increased intracranial pressure. However, some of these cysts grow more slowly, allowing the patient to accommodate the mass without disrupting cerebrospinal fluid flow, and the patient can be asymptomatic over a large number of years. The colloid cyst, however, is a classic example of a benign mass in a malignant location. Because of its ability to produce sudden and complete obstruction of both lateral ventricles, there may be acute ventricular enlargement causing central midline herniation. In this example, we can see a large colloid cyst causing obstruction and dilatation of both lateral ventricles. This MR scan in the coronal plane is from a different patient, but illustrates almost identical features of a large 20 millimeter colloid cyst producing obstructive hydrocephalus of both lateral ventricles. The lining of a colloid cyst is typically ciliated, cuboidal to low columnar, oftentimes pseudostratified. The cells have blepharoplasts and cilia, and they may also show goblet cells. The lumen will contain a mucous material which can be high in protein and relatively inspissated and dry, as illustrated here. So the colloid cyst is a lesion located at the third ventricle near the foramen of Monro. It's sharply demarcated on CT, but can have variable attenuation. On MR, it's in the same location, sharply demarcated, but it also has variable signal intensity. Some colloid cysts, which are dark on the T2 weighted image, are too viscous to allow stereotactic aspiration. And in these cases, ventricular endoscopic surgery is needed for treatment or removal of the colloid cyst. Here's another example of a colloid cyst showing a little bit of hydrocephalus. We can see that this one is also hyperattenuating, located at the junction between the lateral ventricles and the third ventricle. And because the ventricles are larger than the sulci, we suspect some element of obstructive hydrocephalus. Here is another example of a hyperintense colloid cyst in the anterior third ventricle, just at the origin of the internal cerebral veins, which are shown as flow voids, ending up joining the basal veins of Rosenthal to form the great vein of Galen, and then subsequently the straight sinus. This is another example of a somewhat larger and hyperintense colloid cyst, and we want to remember that these that are hyperintense are more likely to be associated with symptoms and perhaps with ventricular obstruction. This particular case was associated with a partially empty sella from intermittent increased intracranial pressure and hydrocephalus. Another colloid cyst illustrated here is also hyperintense on T2 weighted image, but we can see that on the T2 image the center of the lesion has become hypointense. This one would probably be too viscous to be aspirated through a needle and would require a ventriculostomy or endoscopic surgery. This is what is sometimes described as the black hole effect in the colloid cyst. In considering the surgical approach, a liquid consistency might allow stereotactic aspiration, but endoscopic or ventriculoscopic surgery will work in almost every case. Here is another example on a coronal gross picture of a colloid cyst, demonstrating that there is a large volume lesion which in the center contains some relatively dry and hard inspissated mucus secretions. Here is another example of a colloid cyst, and in comparison, a mass lesion in the posterior part of the third ventricle, which is not a colloid cyst. This is a patient that has cysticercosis. If you look outside the industrialized world, the most common mass lesion of the third ventricle is going to be intraventricular cysticercosis. And these lesions may be recognized by their location being in the posterior part of the third ventricle, and sometimes they may be mobile. So this is cysticercosis. So in summary, the colloid cyst is an uncommon intracranial mass lesion. It represents about 20% of intraventricular masses and is almost always located in the anterior third ventricle. Although slowly growing congenital lesions, they can fill with mucus, which may produce obstructive hydrocephalus, and in some cases can lead to acute, sudden decompensation, herniation, and death of the patient. Thank you very, very much for your attention. I'm Jim Smyrniotopoulos, and I have approved this message.